topic given to me is central nervous system TB. Because of the limited time, I thought I'll confine myself to TB meningitis because tuberculoma and spinal tuberculosis are a different ball game with structural changes seen on imaging. Whereas in TB meningitis, there is no structural lesions seen and to be followed up. And TB meningitis constitutes about 2 to 5% of TB cases, and 500,000 individuals have developed TB worldwide each year. So there are many challenges associated with TB meningitis. One is the difficulty to diagnose, as has been highlighted by the previous speakers, including Ladi sir, because of the low sensitivity of and specificity of the clinical diagnosis and the low sensitivity of most of the diagnostic tests. Again, another challenge is the ability of anti-tuberculous drugs that we conventionally give may not cross the blood CSF or blood-brain barrier, and the bactericidal activity is also very low. Then the other issue is the host intracellular inflammatory response may lead to brain ischemia and infarct, may lead on to raised intracranial tension, intracranial pressure with mass effect. And because patients may be unconscious, they may need critical care management. So these are the main issues associated, challenges associated with TB meningitis. When you look at the epidemiology, which adult and children are at higher risk of developing drug-resistant TB? We have some clues. For example, a person who already had incomplete treatment for tuberculosis may be at high risk. Patients with HIV may have a high risk for drug-resistant TB meningitis, but we have not completely understood why some of them develop drug-resistant TB meningitis. Which adults or children are at risk of dying once diagnosed with TB meningitis? Again, we have not completely understood. The biological characteristics associated with poor outcome is also not completely understood. Some of the adults and children develop severe neurological disability. In my experience, it is the spinal arachnoiditis patients who have more persistent disability than other patients. Then I have to again say that this may be different from other parts of India, because in Kerala we are, I believe that we are diagnosing CNS tuberculosis early throughout the state, and hence we do not have many patients with neurological disability after treatment, but we still have patients with neurological disability in patients who present with spinal arachnoiditis. Then regarding the pathogenesis, we have learned few things about the pathogenesis of TB meningitis, but probably not completely. We know that the bacteria can transit the endothelium directly or through infected cells, and we now have animal models like Mycobacterium marinum in zebrafish, or cynomolgus models of TB, which is a macaque. So now being increasingly adapted as a most representative animal model of human TB. So we are in the process of understanding the pathogenesis of TB meningitis, and we know that patients who had BCG vaccine have less severe disseminated tuberculosis and CNS tuberculosis, and BCG exposed hematopoietic stem cells generate epigenetically modified macrophages, providing protection against virulent Mycobacterium tuberculosis infection when compared to the naive macrophage. This has been understood. Then the inflammatory consequences of TB meningitis are mediated by cytokines or matrix metalloproteinases dysregulation, with consistent association documented for tumor necrosis factor, vascular endothelial growth factor, and MMP9. Then we know that the administration of 1,000 milligrams of aspirin can reduce the thromboxane A2 levels in CSF. A polymorphism in the gene encoding leukotriene A4 hydrolase influences both intracerebral inflammation and survival from TB, and also this is associated with a good response to corticosteroids. So this is in summary the pathogenesis. We know that there are many. Sorry, just take my. There are many inflammatory markers which I've already mentioned, but how exactly this will cause vasculitis or meningitis or encephalitis is not clearly understood. So a lot more need to be learned about the pathogenesis. Diagnosis. I would like to emphasize that the lack of diagnostic suspicion is the most important cause for delay in diagnosis. Patients who present with atypical presentation, even patients presenting with the typical presentation, we may not the tuberculous meningitis or CNS tuberculosis may not come in the differential diagnosis, and hence there is a delay in the diagnosis. But as I have told, in general, in Kerala, the diagnosis seems to be early. Development of the expert ultra, the gene expert ultra are rapid PCR-based tests crucially identifying rifampicin resistance when positive, guiding early therapy. Ultra had a higher sensitivity for Mycobacterium tuberculosis detection in CSF than a gene expert, 44% versus 18%. And even though a gene expert has been said to be very useful, I think in our hands, in clinically diagnosed TB meningitis who respond to anti-tuberculous drugs, probably only 1/4 of patients are tested positive in our hands. We do not know, probably we are not sending only CSF once. No, we are not sending it repeatedly, and that may be the reason. And in a large study looking at 618 individuals across 3 sites, again, against TB clinical diagnosis, the conventional Zeal-Nielsen sensitivity was 33.9. For the modified Zeal-Nielsen, it was 34.5. For culture, it was 31%, and for gene expert, it was 25%. So this may be ground reality, unlike in centers. Using culture as a reference, the Zeal-Nielsen, it was 66%, modified Zeal-Nielsen 67%, and gene expert was 72% respectively. So it was found that high CSF volume and the low CSF blood glucose ratios were independently associated with microbiologically confirmed TB. And 15 to 20 ml of CSF in adults is regarded as safe and feasible. Another test which has come up is the LAM, the lipoarabinomannan antigen found in the cell wall of Mycobacterium tuberculosis. Sensitivity was 21.9% in CSF and with a high specificity. Neuroimaging in TB meningitis, We can detect infarcts early with diffusion-weighted image, and maximum risk of infarct occurs in the first month. Again, we can look at hydrocephalus, which may develop as a complication of TB meningitis. And in TB meningitis, if patient has a communicating hydrocephalus, what we do is a repeated lumbar puncture to reduce the CSF pressure. We can also look at the paradoxical enlargement in the tuberculoma or the appearance of new tuberculoma in TB meningitis patients. Coming to the antimicrobial therapy, the transporters like P-glycoprotein actively pump substances out of the brain into the blood or CSF to protect the CNS from free entry of potentially neurotoxic substances. These same pumps also lower penetration of some of the first-line TB drugs, especially rifampicin and ethambutol. They are pumped out. Regarding the antimicrobial therapy, a meta-analysis showed that the risk of relapse was extremely low, less than 1%. So that is my experience. If a person had adequate anti-tuberculous drugs in the past, the chance that he has a recurrence of a CNS tuberculosis is less than 1%. It is possible, but it is less than 1%. And this meta-analysis also showed that virtually identical results with less than 6 months therapy and more than 6 month therapy. This is from the meta-analysis. Then regarding the new trials which tried higher doses of conventional anti-epileptic, anti-tuberculous drugs, rifampicin administered intravenously, 13 milligram per kilogram, was found to lower the mortality by 50%. And but when it was given orally, 15 milligram per kilogram orally, it was not found to be useful. Probably if it is oral, the ideal dosage would be 35. More studies are needed to confirm this. This is not the standard of treatment as of now. Isoniazid has excellent CSF penetration, but isoniazid is metabolized by genetically polymorphic N-acetyl transferase. So rapid acetylators have lower isoniazid exposure in the plasma and CSF and might benefit from higher doses. Again, studies are needed to confirm this. Fluoroquinolones also have been examined with no effect seen in Indonesia and Vietnam. Drugs under trial, I've already told high dose rifampicin, high dose INH, etc. Similarly, cycloserine, ethylamide, linezolid, and the nitroimidazoles are also being tried now. Again, modification of drug delivery is being tried, liposomal form or the nanoparticle permeated type, and inhibition of the efflux pump, which I had alluded to earlier, might also increase the drug exposure and effect. And then another issue with all anti-tuberculous drugs, whether it's extrapulmonary or pulmonary, is the drug-induced liver injury. Then one of the special problems with CNS TB is the host-directed therapies. The host immune response may be dysregulated, and we have tried dexamethasone and aspirin, thalidomide. We'll come to that. Corticosteroids, they have been found in CNS TB, in TB meningitis, has reduced deaths but do not reduce disability. Their benefits appear heterogeneous. Some patients respond rapidly. We do not know why some respond rapidly and some do not. Probably it is genetically mediated and depends on the presence of the interleukin generation. The mechanism by which they reduce death is also unknown. It activates the glucocorticoid receptors of macrophages and other cells, interfering with the inflammatory mediated transcription and expression. Inhibition of the pro-inflammatory transcription factors such as activator protein 1. Dexamethasone is also used. So dexamethasone or steroid is used in the initial 1 1 month of TB meningitis. It is also used when there is paradoxical reaction or TB iris in HIV infected persons. One of the hypotheses is that for the host response dysregulation is that tumor necrosis factor is critical cytokine in TB meningitis pathogenesis, and its inhibition may improve clinical outcomes. To this end, thalidomide and anti-TNF biological drugs have been studied. I know many neurologists who tried thalidomide have given thalidomide only to one person. So thalidomide is proposed, is given for steroid unresponsive optochiasmatic arachnoiditis resulting in visual impairment and or optic and enlarging TB abscess despite corticosteroid therapy. Large TB abscess or tuberculoma in critical brain regions like the brainstem, which is not amenable to surgical drainage and not responding to corticosteroid. Large dural-based TB abscess resulting in epilepsy. Continue. Then stroke is associated with a twofold increase in the mortality in a recent meta-analysis. And at the moment, there is no sufficient evidence to give aspirin regularly. There are few studies like this where a low dose versus a high dose 1000 milligram of aspirin for the first 60 days treatment of 120 adults complementing clinical response assessment with CNS brain and measuring lipid inflammatory mediators and CSF. The results suggested higher dose of aspirin may reduce infarcts and death. In the critical care, there is no consensus on the optimal care for controlling the raised intracranial pressure, the role of the indication for medical therapy. There is no consensus. And there is the criteria for surgical intervention or the choice of surgical techniques. Each center has their own way of treating hydrocephalus. The raised ICP can be monitored very easily by ultrasound. You look at the optic nerve sheath diameter, which we can do repeatedly. Transcranial Doppler studies can show you that with raised intracranial pressure, the mean flow velocities increase in all the major vessels like middle cerebral artery vessels bilaterally. To control the intracranial hypertension, I would suggest to give hypertonic saline rather than mannitol, because one of the complications with CNS tuberculosis is SIADH or cerebral salt wasting with hyponatremia. Then other shunt procedures, external ventricular drainage in emergency situations, ventriculoperitoneal shunt, etc. can be done. Raised ICT can be also due to tuberculous abscess or associated cerebral venous thrombosis, which can occur rarely. Head elevation to 30 degrees is a good idea. Altered sensorium may be confounded by hyponatremia. Maybe non-convulsive status or maybe medications that you're using. Hyponatremia may be due to cerebral salt wasting or due to SIADH. In cerebral salt wasting, there will be hypovolemia, whereas in SIADH, there is euvolemia. That is a basic difference between the two. But it may be difficult to differentiate the two. Then the long-term problems are in unconscious patients, central line infections, urinary tract infection, endotracheal intubation, bed sores, DVT. Prognosis may depend on the baseline characteristics on the GCS level when the patient came, or it may also be complicated by complications like stroke or paradoxical reaction, which may develop later during the course of the treatment. Now there are many clinical trials are there. High-dose rifampicin and lasolate with or without 1000 milligrams of aspirin, the laser TB trial, the SURE trial in children with aspirin 20 milligram per kilogram, the last ACT with personalized anti-inflammatory therapy for patients who have problems with the leukotriene A4 hydrolyzed gene type. So in the allotted time, I have tried to cover some of the facts which are not known in TB meningitis, some of the recent understanding of TB meningitis and the further trials that are going on. I'll take questions from you. Thank you so much for giving me this opportunity to talk on TB meningitis. Thank you.